Hello everyone! So for today's report, me and my groupmates are going to talk about the topic that was assigned to us, and that is the neurocognitive disorder. So before we begin our report, it is very important to take note that in our report, we use two sources, the ICD-11 and the DSM-5-TR. The differences is that the ICD-11 used the neurocognitive disorder as a broad category, and the DSM-5-TR uses the the neurocognitive disorder term in a more specific terms, in which you will find that it mentioned about major neurocognitive disorder and mild neurocognitive disorder. So also it's very important to take note that there may be some terms that you will find on the ICD-11 that are not in the DSM-5-TR, and there are also terms that you will find in the DSM-5-TR that are not in ICD-11. So now, let's have an overview of what really is a neurocognitive disorder. So neurocognitive disorder is a general term that describes a decrease in mental functions due to a medical disease other than the psychiatric illness. And also, as I've said, you will encounter the term major and mild neurocognitive disorder in the DSM-5-TR, which exists on a spectrum of cognitive and functional impairment. The term major neurocognitive disorder corresponds to the condition what is referred to in the DSM-4 as dementia. The core feature of neurocognitive disorders is an acquired cognitive decline in one or more cognitive domains, which are based on the following that you can see in front. So that leads us to our next slide, which are the what we call as the neurocognitive domains. So before we tackle on about the diagnostic criteria, it is very important for us to take note that the criteria for the various neurocognitive disorder are based on the 5 cognitive domains. So nakabase po siya sa mga cognitive domains, yung mga diagnostic criteria na makakita natin as we follow along. This includes Number 1, complex attention. Number 2, executive functioning. 3, learning and memory. 4, language. 5, perceptual motor. And 6, social cognition. So, nakabase po dyan yung mga various criteria of NCDs. Dyan po siya nakabase. So, you will just read po about it. So, we'll begin now with our report. These are the categories of neurocognitive disorders. So, let's start with delirium. First is delirium. The ICD-11 code for delirium is 6D700. So what is delirium? When we say delirium, it is a sudden disturbance of attention, awareness, and orientation which causes significant confusion and fluctuating cognitive impairment. It often involves behavioral and emotional changes, sleep disturbances, and may affect multiple cognitive areas, which causes Causes include medical conditions, substance use withdrawal, or unknown factors. So in short, delirium is a sudden and serious change in how a person thinks and behaves. It usually happens quickly over hours or days and affects few areas in mind, such as attention, awareness and orientation, and thinking. So now, let's proceed to its diagnostic criteria. First is a disturbance in attention accompanied by reduced awareness of the environment. So what this simply means is hindi makafocus yung client, madaling ma-distract, parang wala sa sarili. Letter B. The disturbance develops over a short period of time, which represents a change from the baseline attention and awareness and tends to fluctuate in severity during the course of a day. So, what this means is medyo alert yung client sa umaga, pero parang malabong pag-iisip sa gabi. That's another example. Letter C is an additional disturbance in cognition. Pwedeng hindi makaalala, memory loss, or nagkakaroon ng hallucinations or delusions. Letter D, the disturbance in criteria A and C are not better explained by another pre-existing established or evolving neurocognitive disorder and do not occur in the context of severity, reduced level of arousal such as coma. And then letter E, there is evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical conditions. So, substance intoxication or withdrawal or exposed to a toxin is due to multiple etiologies. What this simply means is dahil sa, we can say that delirium is caused by a medical condition, withdrawal or combinations. Now, it is very important to take note that delirium is not dementia. It is very common in elderly patients, lalo na kung may sakit, nasa hospital, or naka-confine sa ICU. And early recognition is very important para maiwasan natin ang complications. Now, these are the additional clinical features. What this simply means is delirium is a sudden conditions where one's overall thinking, cognition becomes confused and disorganized, affecting memory, focus, understanding, and judgment. It can cause problems like problems with perceptions, illusions, misinterpreting real things, delusions or false beliefs, hallucinations, or hearing and or listening to something that is not existing. Emotions can be unstable with symptoms like anxiety, sadness, or anger. Yun lang po yung laman ng additional clinical features. Next is we should specify if it's acute. When we say acute, it is lasting for few hours or days, and persistent, it lasts for weeks or months. We should also specify if it's hyperactive. When we say hyperactive, the individual's level of psychomotor activity may be accompanied by mood lability, agitation. Agitation is aligaga, and a refusal to cooperate with medical care. We should also specify if it's hypoactive, the individual has a hypoactive level of psychomotor activity that may be active with sluggishness and lethargy that approaches stupor, and or mixed level of activity. The individual has a normal level of psychomotor activity even though attention and awareness are disturbed. Also includes individuals whose activity level rapidly fluctuates. And specify whether substance intoxication delirium. When we say substance intoxication delirium, is that the diagnosis should be made instead of substance intoxication when symptoms in criteria A and C predominates in the clinical picture when they are sufficiently severe or warrant clinical attention. So those are slide explanatory na po. So now, let's move to the subcategories under delirium. So you will find out that there are actually 5 subcategories under delirium. First is delirium due to disease classified elsewhere. Second is delirium due to psychoactive substances including medications. Third is delirium due to multiple etiological factors. And fourth is delirium or due to other specified cause in delirium unknown or unspecified cause. Unspecified cause. Okay, now let's move to delirium due to disease classified elsewhere. When we say delirium due to disease classified elsewhere, these are the diagnostic criteria. Letter A, all the diagnostic requirements for delirium are met, which I have discussed a while ago. Letter B, there is evidence from the history, physical examinations, or laboratory findings that the neurocognitive disorders is caused by the direct physiological consequence of a medical condition. So, as I've said, before we can say that the delirium is due to disease classified elsewhere, there should be an evidence from history or physical examination that this delirium is really caused by these kinds of conditions. Also, the judgment depends on establishing the following conditions. Letter A, the medical condition is known to be capable of producing delirium. And letter B, the course of delirium onset trajectory of symptoms response to treatment is consistent with the causation by the medical condition. So it is proven that yung delirium consistent siya with the effect of the medical condition. Next is we should take note that when delirium is due to a disease or condition classified elsewhere, the diagnostic code corresponding to that disease or condition should be assigned along with delirium due to disease classified elsewhere. So if delirium is attributed to multiple conditions or to a medical conditions and a substance, the category 6D070.2, delirium due to multiple etiological factors should be used instead. So delirium, what this simply means is delirium is caused by, let's say, only one disease or conditions classified elsewhere. But if it's caused by multiple conditions, multiple medical conditions, we should use the code 6D70.2 instead, which accounts for delirium due to multiple etiological factors. So let's move on to letter B. Delirium due to psychoactive substances, including medications. So the ICD-11 code for this would be 6D70.1. So now, what are the diagnostic criteria under this subcategory? Letter A. All diagnostic requirements for deliriums are met. Letter B. There is evidence from history, physical examination, or laboratory findings that the neurocognitive disturbance or the delirium is caused by the direct physiological consequences of use of a substance or medication. Again, and this judgment depends on establishing the following: that the substance and the amount of duration of its use or withdrawal from the substance is known to be capable of producing the delirium. Letter D. The course of the delirium, onset, trajectory of the symptoms, eventual remission with elimination of the substance is consistent with the causation by the substance. What this means is that the delirium is caused by a substance like alcohol, drugs, or medication that follows a predictable pattern based on the substance effect on the body. Letter E is the duration or severity of the symptoms is substantially in excess of the characteristic symptoms of substance intoxication or substance withdrawal due to classify specific substance. So, what this E means is that yung mga may sintomas ng delirium ay mas matindi o tumatagal ng mas mahaba kaysa sa mga karaniwang symptoms ng withdrawal from a substance. Halimbawa, kung ang isang tao ay nag-stop ng gamot, maaring may mga simptomas ng pagkalito. Ngunit, pag sinabi nating delirium, mas mahirap kontrolin kaysa sa mga karaniwang effect ng pag-withdraw ng isang tao, isang client sa gamot or pag-inom sa isang substance. Okay, now, next is delirium due to multiple etiological factors. So what are the diagnostic criteria under these? Letter A, again, all the diagnostic requirements for delirium are met. Letter B, again, there is evidence from the history, physical examination, or laboratory findings that the delirium is caused by either the direct physiological consequence of multiple disease classified elsewhere, or one or more disease classified elsewhere and the direct effects of a substance or medication on the central nervous system. Letter C, the judgment depends on establishing the following. The medical conditions are known to be capable of producing delirium. Yung medical condition na sinasabing nagkakos ng delirium is really capable of producing the delirium. If applicable, second is if it's applicable, the amount and durations of use of the substance or withdrawal from the symptom is known to be capable of producing delirium. C, if capable, the duration applies or severity of the symptoms is substantially in excess of the characteristic syndromes of substance intoxication or substance withdrawal due to specified substance. So, the symptoms, what this means is the symptoms last longer or much stronger than what is typical for intoxication or withdrawal from the specified cause, which I have discussed from the previous. Mas matagal, mas mahirap yung symptoms ng delirium as compared yung normal na symptoms kapag nag-withdraw yung isang clients from a substance use. And D, the course of the delirium, onset, trajectory, eventual remissions with elimination of the substance from the body is consistent with causation by the medical conditions and, if applicable, the substance. Okay, now let's move to letter D. That would be delirium, other specified cause. So, the code for that is 6D70.Y. So, Na diagnostic criteria for this is letter A, all the diagnostic requirements for delirium are met. B, the delirium is presumed to be attributable to an identified cause that is not adequately captured by any of other available delirium categories. So what this means is that yung delirium, sanhi ng specific na dahilan na hindi pasok sa other categories ng delirium. Letter C, the judgment depends on establishing the following. Number 1, the specified cause is known to be capable yung specified cause of producing the delirium. Number 2, the course of delirium on age onset trajectory is consistent with the specified cause. And we should also take note that the ICD-11 diagnosis corresponding to the presumed etiology should also be assigned. So next, this would be the last, delirium, unknown or unspecified cause. So the code for this, ICD-11 code for this, would be 6D70.Z. There is no specific definition, diagnostic criteria. There was no diagnostic criteria that was given to this, but if we're basing from the previous report, what this simply means is that the psychiatrist cannot give a specified cause for the reason behind that delirium due to various factors, either lack of information or others. Next is other specified delirium. When we say other specified delirium, this category applies to presentation in which symptoms characteristics of delirium that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for delirium or any other disorders in the neurocognitive disorder diagnostic class. This other specified delirium, by the way, is in the DSM-5-TR, but that is in the ICD-11. So what this statement means is that when we say other specified delirium, it refers to when the symptoms resemble delirium but do not fully meet the criteria for delirium or any neurocognitive disorder. Next is unspecified delirium. This category applies to presentation in which the symptoms, characteristics of deliriums that cause clinically significant distress or impairment in social, occupational, or other important areas of functionings that predominate but do not meet the full criteria for delirium or any of the disorders in the neurocognitive disorder diagnostic class. That specified delirium category is used in the situation in which the clinician chooses not to specify the reason that the criteria are not met for the delirium and includes presentation for which there is insufficient information to a more specific diagnosis. So this unspecified delirium is similar to this delirium unknown or unspecified cause. Ito kasing dito sa previous slide, itong delirium unknown or unspecified cause, this is from, let me correct, this is from ICD-11, not from DSM-5. Tapos, dito sa DSM-5 yung sinabi dito as unspecified delirium. So, same lang sila. This is what it means. Unspecified delirium is a catch-all category for a situation where someone seems delirious but the doctor can pinpoint the exact cause or it's a full-blown case of delirium. So, to understand our topic, let's go through one case vignette. This is delirium not induced by alcohol and other psychoactive substances. So it's quite very long to read, so I will just explain it. So the case vignette describes a 55-year-old man who developed delirium after a fall and subsequent surgery. As we can see, there is a medical history where he suffered a femur fracture and underwent surgery and was placed in the post-operative ward for monitoring. And then a psychiatry consultation was requested because the man was showing signs such as restlessness and irritability. Aside from that, as we can see, nag-show siya ng mga symptoms ng delirium, which are the following. One, he was agitated and attempted to remove his IV cannula and leave his bed. That's what happened when the man was taken to the hospital and was confined to the hospital. Second, his speech was incoherent and difficult to understand by doctors and nurses. So, when he talks, hindi masyadong naiintindihan. It's very incoherent, difficult to understand. Third, despite repeated instructions to stay in bed, he was non-complaint and became aggressive, using offensive language when approached by medical staff. So, um, he was very aggressive. Take note po of the term aggressive. And then he was unable to sleep while other patients were resting. And his behavior disturbed neighboring patients, necessitating physical restraint. Now, on examination, the man exhibited increased psychomotor activity. He also showed signs that of clouding of consciousness, meaning he was confused and unable to stay aware of his surroundings. He was disoriented to time, place, and person, meaning that he didn't know what time it was, or where he was, or who he was. And his attention was impaired. He had also difficulty in immediate and recent memory, meaning that he couldn't remember the recent events or things that just happened. So that's basically what the case vignette is saying. So those are what was shown by that patient. So the diagnosis would be, since the man's symptoms, which take note, restlessness, confusion, disorientation, hallucination, and memory impairment, are consistent with the delirium. So, delirium is often triggered, as I've discussed, by factors like either surgery, medications, infections, or other medical conditions, which was written on that first part na he was operated. Now, um, in this case, it's likely that his delirium was triggered by the surgery or the hospital environment or possibly the medications. So, delirium can be temporary though, but it requires prompt attention and treatment to manage the underlying cause and the symptoms. Okay, so now let's move to the next topic, which would be amnestic disorder. So, um, ano ba ang amnestic disorder? When we say amnesia, it refers to the loss of memories, including facts, information, and experiences. Movies and televisions tend to depict amnesia as forgetting your identity, but that's not generally the case. Instead, people with amnesia, also called amnestic syndrome, usually know who they are, but they have trouble learning new memories and forming new memories. So, kung ano yung napapanood natin sa TV, hindi ganun yun. So, hindi parang yung kumabit, tapos yung lalaki nahulog sa bangin, tapos nakalimutan niya kung sino yung first na asawa niya, tapos pumusta sa mistress. Hindi ganun ang amnesia. Let's take a look at the general diagnostic criteria for us to be able to understand more what is amnesia. Number one, prominent memory impairment relative to expectations for age and general level of promorbid neurocognitive functioning. In the absence of others, significant neurocognitive impairment is required for diagnosis. So, what does this mean? The person has serious problems with memory that are much worse than what you expect of their age or how they used to function mentally. Other thinking skills such are mostly okay. And next, when we say B, the memory impairment represents a marked decline from previous levels of functioning. So what does this mean too? Yung memory problem niya is clearly much worse than how a person used to remember things. The memory problems are clearly worse than the normal way of how a person doesn't remember certain things or makakalimutin. Letter C, the memory impairment is characterized by reduced ability to acquire, learn, and or retain information. Yung main problem kasi is with how learning new information or remembering recent things. Not so much that forgetting things from a long, long time ago or um, yung parang sinabi ko kanina, nakalimutan niya yung asawa niya tapos as in wala. That's how usually is depicted in drama. Letter D, evidence memory impairment is based on number one, information obtained from the individual, an informant or clinical observation, and number two, substantial impairment in memory performance as demonstrated by standardized neuropsychological cognitive testing or in its absence, another quantified clinical assessment. So, there's a solid proof that the memory issue is like the person talks about it or someone closest to them notice it, and the memory tests show that they're doing much worse than expected from their age. Letter F, the symptoms result in significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. In mild cases, if functioning is maintained, it is only through significant effort. So, now, um, there are things that we should take note when it comes to this amnestic disorder. Number one, it's when amnestic disorder is due to a disease, condition, or injury classified elsewhere, including diagnostic codes corresponding to that disease, condition, or injury should be assigned along with the amnestic disorder. When the etiological condition is unknown, the diagnosis 8A27 disorders with neurocognitive impairment as a major feature as specified may be assigned in an addition to amnestic disorder. Now, another thing to take note is that normal aging is typically associated with some degree of memory change. A diagnosis of amnestic disorder does not apply if performance is consistent with the expectation for the individual's age based in age-related norms for performance and standardized assessment. When memory difficulties consistent with normal aging are present and clinically relevant, the symptoms code MB21.0, each associated cognitive decline, may be used. So what does the first point mean? Ang pagtanda ay karaniwang may kasamang kaunting pagbabago sa memory. Hindi pwedeng sabihin na may amnestic disorder ang isang tao kung ang memory niya naman is normal na expected para sa kanyang age based from age-related norms ng memory test para sa iba't ibang edad. When memory difficulties is consistent with normal aging are present and clinically relevant, the symptom code would be MB21.0 or age-associated cognitive decline may be used. That's it. Now, let's take a look at the different amnestic disorder subtypes. So these are the subtypes under amnestic disorder. Letter A, amnestic disorder due to disease classified elsewhere. B, amnestic disorder due to psychoactive substances, including medication. Under these are amnestic disorder due to use of alcohol, amnestic disorder due to use of sedatives by hypnotics or amuletics, amnestic disorder due to other specified psychoactive substances, including medications, amnestic disorder due to one of volatile inhalants, amnestic disorder other specified cause, and amnestic disorder order unknown or unspecified cause. So by the way, this amnestic disorder is written in, you can find this in the ICD-11. So, first let's start with amnestic order due to disease classified elsewhere. So, let's try to understand this by first going through its diagnostic criteria. So, number one, all the diagnostic requirements for amnestic disorders are met. Then number two, there is evidence from history, physical examination, or laboratory findings that the symptoms are caused by the direct physiological consequences of mental conditions, disease of the nervous system, a traumatic injury, an infection, a tumor, another disease, process affecting areas of the brain. It involves memory, and the judgment depends on establishing the following. So let me explain first the point two, which I keep saying this a while ago. There's a clear evidence from history, physical examination na yung tong kinds of amnestic disorder is caused by a specific medical condition, which are the following that I have said a while ago: brain injury, infection, tumor, or other nervous system disease. And then to confirm that the medical condition is the cause, you must know that the condition is capable of causing the memory problem. This is what they say, and that also the way the memory issue started and developed matches what you expect from that condition. Now, what about amnestic disorder due to psychoactive substances, including medication? For these are the diagnostic criteria. Number one, all the diagnostic requirements for amnestic disorder are met. Number two, again, there is evidence from history, physical examination, or laboratory findings that the disturbance is caused by the direct physiological consequences. Number three, the substance or medication and the amount of duration of its use is known to be capable of producing the memory disturbance. So, um, what this means is that the key points for to confirm this diagnosis is that the drug or um, substance is used known to cause memory problem. For example, heavy alcohol or use of sedative abuse is known to damage memory, and that also the timing and pattern of the symptoms match the use of the substance. The memory loss started and progress in a way that makes sense given the substance used. So these are the additional informations. Let's read. A diagnosis corresponding to the pattern of the use of relevant psychoactive substance, episode of harmful psychoactive substance use, harmful patterns of psychoactive substance use, substance dependence may also be assigned. Note that the other categories under 6D 72.1, amnestic disorder due to psychoactive substance, including medication, is, is different from that of other parallel identities, substance-induced dementia, below, in which the other specified category is listed last. This difference is not meaningful. So, the statement means that in addition to diagnosing an amnestic disorder or memory problems, a doctor can also give another diagnosis that describes the pattern of how the person is using a psychoactive substance like alcohol, drugs, or medication. Now, the difference is take note, the difference is not meaningful, that the categories should be used in the same way, such as, let's read the following. This should be the coding note that 6D72.10 codes for amnestic disorder due to the use of alcohol. 6D72.11 amnestic disorder due to use of sedatives, hypnotics, or anxiolytics. 6D72.12 amnestic disorder due to another specified psychoactive substance including medications. 6D72.13 amnestic disorder due to the use of volatile inhalants. Now, let's move to the next slide, which would be amnestic disorder, another specified cause, which the code would be 6A72.Y. So, here's the diagnostic criteria. Number one, all the diagnostic requirements for amnestic disorder are met. Number two, the amnestic disorder is presumed to be attributable to an identified cause that is not adequately captured by any of other available amnestic disorder categories. Yung meaning nito, may natukoy na sanhi. Halimbawa, isang condition or disorder or sakit na hindi sakop ng other categories ng amnestic disorder. Next, the judgment depends on establishing the following. The specified cause is known to be capable. Again, capable siya, yung natukoy na sakit, capable siya of producing this amnestic disorder. And the course of the amnestic disorder, onset, trajectory of symptoms, response, treatment is consistent with the specified cause. So, in short, kung may memory loss ang tao at alam natin ang sanhi, pero hindi ito pasok sa ibang standard categories, pwede pa rin tawaging amnestic disorder, pero yung cause niya, mas kilala or mas kilala yung symptoms and may alam na specific cause. Next slide would be amnestic disorder, unknown or unspecified cause. So, it's just same with other with the other kinds of disorders which was discussed. If we said unspecified cause, the psychiatrist cannot really specify what the cause due to various reasons like lack of information and more. Now let's take a look at this case vignette, which is Alzheimer's dementia. I'll read it for you. A 69-year-old married male person with education up to MA was retired clerk from an urban background belonging to middle socioeconomic status was brought for consultation by son with complaints of forgetfulness since 4 years. He had no significant medical history. His son tells him that the doctor that from the past 4 years, his father has become forgetful and does not remember whatever he does. He does not remember what he has eaten. He keeps asking for food frequently, saying he did not have any food. He forgets where he kept his money, his bike, and blames family member that they are misplacing them. He has stopped going for a morning walk, meeting friends, and reading newspapers. Though he is staying in the colony from the past 40 years, he is missing the way to home from 2 years and lands up in a neighbor's house. He does not brush the teeth properly after brushing and washing mouth. The latter would remain back around his mouth in the same way after bathing. Water and lather remain on the body. While dressing up, he forgets to button up his shirts. He spills food stems out of the plate while eating. His family members are helping him every day for brushing teeth, taking bath and dressing from the past 1 year. On mental status examination, he appeared ill-kempt. Eye-to-eye contact was made but ill-sustained. It was cooperative with examiner, but rapport was poor. He gave wrong answer for time, date and year. He could not saw which season was going on. He could not identify where he was, in which floor of the building, how he traveled to reach the place. But he could identify family members. As I've said, hindi siya kagaya nung nakikita natin sa TV. Immediate and recent memories were impaired. He was unable to recollect 3 unrelated words given to him immediately after 5 minutes. His remote memory was intact, so he could recollect and say where he was born and brought up, in which studies he did studies. Confabulations were seen, which um which was discussed by mom before kapag confabulation is creating false memory or falsifying, creating false memory. Fund of knowledge was poor. Abstract thinking was at concrete level. He gave wrong differences between apples and orange. He was unable to tell similarities. He was to do single digit arithmetic calculations with prompts. Insight was poor. Laboratory investigation ruled out any systematic illness to explain the symptoms. So, yung findings dito would be Alzheimer's dementia because the following were seen. Number one, memory impairment, disorientation, functional decline, cognitive impairment, behavioral signs, yung ill-kempt, poor eye contact and rapport, yung hindi makatitig sa mata, ganun. Tapos withdrawn from social and routine activities. Thus, as you can see, while he was being interviewed, there were things that he couldn't remember. So this is another example of Alzheimer's dementia.